Well, hello. My name is Dr. Perry Meyer, and I am the medical director of the Meyer Institute, a center of excellence dedicated to the treatment of the diabetic foot. And today is April 1st, 2020, April Fools Day. No joking around here because we now are into our third day this week of clinic here running a wound center under the cloud of COVID-19, and I think that we've done pretty well. But every day that we are here, we are learning more about how to run a high-risk practice like this under difficult circumstances, and I'd like to share those with you. I think that it would be helpful if other clinicians took up this cause and helped with the stemming the stream of diabetic wound patients going to the emergency room and clogging up their trolleys. I think that it's important that we understand what our role is here, and we are acutely aware that our diabetic patients are high risk and will end up with some form of emergency if left untreated. And for that reason, we are in existence and we are up and running. Some of the things that I have observed that we are trying to deal with on a day-to-day basis, I'd like to share with you now. The first thing is what to do with our clothes, and what we are doing now, although I am in my Harry Potter outfit today, we are going to be switching to some kind of outfit, either scrubs for me, although I don't like wearing scrubs, but it may be like a coverall that I will have a few of, and I will leave here. And so when I come to work, I will put that on, and then I'll have either the disposable lab coats that I wear, or the gowns that the nurses wear over top of this. And when I'm operating, then I'll put on an operating gown as I would do normally. But the idea is that we are leaving what we feel may become contaminated here at work and not bringing it home. And when we are here, we are using a lot of UVC lighting. So UVC light here has been common. We've used it for many, many years to sterilize the field, do our work surfaces, as I said in the previous videos. We were in need of something to deal with the field, plus hard surfaces. Using Cavicide to deal with the hard surfaces is fine, but doesn't always get into all the crevices. UVC light does. The same goes for our clothing. So now the team here, the nurses are coming in scrubs and then taking the scrubs off here before leaving and getting into the street clothes before going home. Those clothes are now put into a bag, and either we will, as per the guidelines now for Hamilton Health Sciences, are suggesting to put them into a Ziploc bag or a paper bag and leaving them for 5 days. So that means you have to have rotations of clothes to accommodate 5 days or 4 days of your work cycle. But then you retrieve those clothes, wash them as normal after the 5 days. Our PPEs, so we are going to run out of our personal protective equipment. Our gowns, we have about now 300 gowns, but that certainly is not enough to be used as per the guidelines, which would be with every single patient. That cannot happen. So we must conserve those. Plus, we need to reuse our surgical masks. We are now exploring ways to reuse our surgical masks if they don't become too soiled. We are now using the UVC lighting, and I'll show you a setup that we have of how we've set up our UVC lighting station, which is a tripod-like affair with a bar, T-bar, with UVC lights hanging from it, and then irradiating the items below, which are our plastic shields as well as our surgical masks. That's going to be adopted, I think, by HHS in the near future as a means to sort of extend the wear time of these personal protective equipment, like the masks, like the shields. The gowns are difficult because they become soil. You have to discard them. So the idea is that we are utilizing the personal protective equipment until it's not useful anymore or it's starting to deteriorate. But until then, we try to keep them as clean as possible. Don't touch your hands to your masks if possible. But we will probably be out within 2 to 3 weeks. So we are hoping that our supplier can restock us with our masks and gowns and gloves. We're going to go through those probably within the 2 to 3 weeks as we go through hundreds of gloves per day. So that's a consideration and a worry for us, how we're going to deal with that. The other issue that I think is super, super important, and one that we are kind of excited about, is the ability to educate our patients when they come here for their wound appointments. Not only do we educate about COVID and about personal hygiene, separating ourselves properly, appropriately out in public, what to do when you go into a store if you have to, wearing gloves, using hand sanitizer frequently, both when you go in to a building to ensure that you are clean when you go in, wearing gloves when you go in, doing your business, and then coming out, and then disposing of the gloves, and then sanitizing your hands. So this is the routine that we go through here, and we are trying to be rigid about the protocol so that every single patient does exactly the same thing. To deal with the hard surfaces out in the reception area, my executive assistant, Emily Bertrand, she puts on some gloves and gets out there and wipes down the chairs with Cavicide as well. So we are trying to do that at least 3 times or 4 times a day, and to ensure that our areas in the clinic waiting a reception area are as clean as they can be. One last note, which I mentioned previously about long-term care facilities. We are not seeing patients from long-term care facilities, and we need to ask those questions of those patients coming in. And we've had now 3 people come from long-term care facilities who minimize their stay there. And I think it's important that we make it clear to our patients that we are really, really sorry that they are inconvenienced in this way. However, if we are to be true to our infection control, we must exclude those patients that are at super high risk, and those being from long-term care facilities. I think that as we move forward, we will have assurances from those facilities that they are infection-free, but until that time, we have to be rigid about the protocols coming into the center, and we are trying our best to be very disciplined about who we see and who we don't see. We are getting lots of education from the TV, probably too much, but nevertheless, they're keeping us informed, and I think that's really key to open and honest conversation and dialogue amongst from the officials of government and the health authority through to us as physicians, as well as clinical centers such as ours. It's important to get the message out, and they're doing it in all kinds of ways. I got this in the mail. This is from Health Canada, and it lays out steps to help reduce the spread of COVID. This is excellent. It's simple. There's a little bit of an infographic. It allows us to review, or the patients to review, what the salient features are about prevention and what they need to do, and they can keep this in their house and pin it up up on their cork board. Lastly, I wanted to talk a little bit about some other information that's been put out there. There are many clinicians who are working on papers about COVID, but a YouTube video that my friend Professor Andrew Bolton out of Manchester is a world authority on the diabetic foot and diabetic foot disease, as is he a expert in endocrinology as an endocrinologist. He put out a very good YouTube video that I will put a link on here, which lays out some of the important points about our diabetic foot patients. These are the most high-risk patients with regards to contracting disease, as they are immunocompromised individuals. Certainly the patient that has, the diabetic patient that has tight glycemic control, the data now demonstrates during this pandemic, both in Italy and in China, that the outcomes for those diabetic patients who went into hospital who had tight control was much better than those who did not. So therefore, during these difficult times, it is still really critical to work on our patients' glycemic control, get their targets in line so that they are in the best shape that they can be in should they contract this virus. It is really important to understand that these wound centers exist to keep the high-risk diabetic foot patient out of the hospital. And these patients, if left untreated, will arrive there because they're all dealing with wounds, and sooner or later, the wounds will become infected and these patients will become very sick and land on the laps of the ER staff who will be overburdened with the COVID pandemic patients. So it's important that we try in any way to reduce the burden of the emergency rooms by doing our part out in the community for wound care, whether it be virtual care or clinic care in a wound center that's outside of the hospital setting, or simply telephone work. So it is important to keep the education, keep informing the patient, giving them useful information that they can use to manage their own wounds, and then obviously provide care in the clinic setting to do the debridement and the wound management of these very sick patients. From a virtual care perspective, I just want to leave everybody with a bunch of different avenues to go down with regards to virtual care. The easiest one probably is FaceTime, but Duo is another on Android. Zoom is very popular, very easy to develop a Zoom meeting, or where you could have multiple people on there, whether you have yourself and then a patient and maybe remotely a patient's family member, daughter, son, whatever, sister, that can be also on the call, and it all can be put together very quickly. Skype is another way to do this. In our EMR, we use electronic medical records is Accuro, and Accuro has an add-on piece called Medio, which integrates, so it is much like Zoom or FaceTime, but it is integrated into our electronic medical records, so we can schedule an appointment with the patient, have that appointment, and all of that has transpired, whether it be video or pictures or simple text, is automatically incorporated into the electronic medical records. And that makes for easy documentation, as well as for your billings. So your billings, if we're doing virtual care, there are billing codes now for that virtual care, and we should be using those. So I hope that this has been helpful. We will be back in a few days to comment on the end of the week and what we have found to work the best. I'll be updating you a little bit more on the UVC lighting, and perhaps getting some feedback from external sources like Hamilton Health Sciences, and seeing what they are doing to deal with their crisis within the hospital confines. My name is Dr. Perry Meyer, and I am the medical director of the Meyer Institute a center of excellence dedicated to the treatment of the diabetic foot. Until next time, stay safe, stay 6 feet apart, use lots of hand sanitizer.